Hello everyone and welcome to Health Talk. I'm your host, Jill Fraley Johnson. Of course, Health Talk, a service of Pikeville Medical Center. Today I am honored to have two of our wonderful physicians with us, Dr. Naveed Ahmed, Dr. Michael Antomasiaris. Gentlemen, welcome to Health Talk.
Thank you.
Thank you.
Both of you have joined us before for Health Talk, so you're no stranger to the program, but this is the first time that you are appearing together, and we are really excited to have both of you with us today. Before we begin, as we always do, we're going to introduce you to our audience a little bit and tell us a little bit about yourself, Dr. A.
Well, I'm a cardiologist, and I subspecialize in electrophysiology, which is the treatment of irregular heart rhythms and all that entails. So we deal with the electrical system of the heart, pacemakers, defibrillators, and different arrhythmias. I was in Lexington for about 7 or 8 years before I moved here about 8 years ago to start the electrophysiology program, and been having a blast ever since.
We're so thrilled to have you. Dr. Ahmed?
Well, I'm a board certified neurologist and I subspecialize in headache medicine and stroke medicine. I've been in Pikeville for the past 20 years and we started the stroke program and the primary stroke center at Pikeville Medical Center. I'm the director of the stroke program and honored to be here.
Like I said, we are honored to have both of you here with us today because we have a very serious topic to discuss, or should I say topics to discuss. We have a cardiologist, electrophysiologist, and a neurologist with us. But the big question is, what do these two specialties have in common?
Stroke.
Well, that's the one big thing. Stroke is the one big thing, obviously. There's some other intersections, but if we had to say it in one word, that would be it, stroke.
Yeah. Each of you talk about the areas of medicine, just mention those that each of you represent and the conditions. But what are the most common conditions, Dr. A, that you treat on a daily basis?
Well, it's a big gamut of patients, and these can range from the nuisance complaint of the patient who's having irregular heart rhythms, and it could be a young person, and it obviously could be very scary to somebody just all of a sudden feel his heart doing strange things that they never felt before. And we can also see very ill patients at their end of their heart disease after they've suffered heart attacks where their heart muscle is very weak and they have life-threatening arrhythmias at that point in time. So it can cause a lot of symptoms without much risk. That's the kind of patient we can see early on, and a lot of symptoms or minimal symptoms but with a lot of risk of complications.
Dr. Ahmed, on a daily basis, what do you see the most of?
Well, nationally speaking, strokes happen every 40 seconds. And in fact, stroke is one thing that we're all concerned about it locally, nationally and internationally. Now, if you look at it, 1 in 40 deaths is stroke. And we classify strokes, since we're here talking about strokes today, they're classified as ischemic strokes or bland strokes or hemorrhagic strokes. Now, Dr. Antomasiaris was alluding to the point that when the heart doesn't beat the way it's supposed to beat, that's one cause of a stroke, and that is called an embolic stroke. And these strokes in particular are bad if they're not recognized early, not treated properly, and of course undertreated as well.
Certainly so. There are different types of stroke that you just mentioned. Discuss the signs and symptoms of each of the types of stroke.
The stroke symptoms in ischemic strokes may be slightly different with the hemorrhagic strokes, but in common, they can have blurred vision, one eye, both eyes, weakness, one side of the face or both sides of the face, speech disturbance. They can be aphasic, what we call as not being able to comprehend, understand, or communicate. Or 4, it can be weakness on one side or both sides, or they can be altered level of consciousness. And the people can also have a bad headache, especially in hemorrhagic strokes. They can have a bad headache, worst headache of their life, and that can be a bleed in the brain. So each symptom has its own priority and the way they present themselves. But think of stroke.
Now, when we think of stroke, there is an acronym that we all need to keep in mind. What is that?
It's called FAST. I think we have discussed this in our previous shows, but the emphasis is on FAST. Face. If there's a facial asymmetry, think of stroke. And if the people have any kind of problems with asymmetry of the face or any speech disturbance, F for face, and A, if there's asymmetry or weakness in their hands, just a slight weakness, there's a drift, think of a stroke. Speech disturbance, not able to speak, communicate, understand, comprehend, think of a stroke. T is for time. Time is brain. The longer you wait, the longer the more brain cells will die, causing more ischemia, lack of oxygen, and hopefully not a permanent deficit.
Most important too, if you start to experience any of these symptoms, make sure you get to a family member that can help you, or certainly to the hospital immediately, because like you said, time is certainly of the essence when you're dealing with stroke or the symptoms too. Now that we understand stroke just a little bit better from Dr. Ahmed's explanation, Dr. A, you have a very important mission that deals with stroke, and it begins with the arrhythmia known as Afib.
Right, or atrial fibrillation. So it's an irregular heart rhythm originating in the top chambers of the heart, the atria. And it can lead, again, to a lot of symptoms, but the main complication, and the one we're most frightened of, is embolic stroke. So what happens is the top of the heart, the atrial chambers, are beating so fast that they're really not creating an effective contraction. So the blood pools there. Whenever the blood pools somewhere, there's a risk of blood clot formation in the chamber itself, and those blood clots can take off, and about 80% of the, a lot of the blood flow, 80% of the chances that those blood clots will go up towards the brain and plug a small artery in the brain and cause a stroke. So the strokes we see with this condition, if not treated properly with blood thinners after the patient's been identified, are not only 5 times the number of the strokes that people without atrial fibrillation get, but also they're about twice as devastating in terms of the 30-day mortality, so how many patients survive the first 30 days or the first 6 months, but also how many patients are up and intact 6 months later. So twice as many are not up and intact 6 months later if they have a stroke associated with atrial fibrillation, compared to the patient that has a stroke not associated with atrial fibrillation.
What do the numbers look like? How many Afib patients suffer from stroke in the United States?
Well, there's about 15 million patients with atrial fibrillation in the United States, and I don't have an exact number to tell you this many have a stroke related to Afib, but about half the strokes in people over 80 years old are associated with Afib in some statistics. So a very high percentage of strokes are associated with Afib, and as the patient gets older and other comorbidities occur together with the Afib, that number goes up.
That's true. In fact, if you look at the composition of ischemic strokes, like Dr. Antimasaris Mike was saying, 20 to 30% of strokes are embolic, and 30% of strokes are cryptogenic. And when we say cryptogenic, after having had a complete workup and excluded other causes of stroke, large vessels, small vessels, then we still have a fraction of about 30% of strokes. We don't know what the cause is, and that's where we as a stroke team, the heart specialists, the cardiologists, and we as a stroke specialists and neurologists try to find out if there's something else that's causing a stroke in that group called cryptogenic strokes.
Signs and symptoms of Afib are not always as obvious as those who are identifying with stroke. Talk about some of the signs and symptoms of Afib.
So there's patients that have what we call paroxysmal atrial fibrillation. That's particularly the kind of patient that we're looking for, because they're not in Afib all the time. So in fact, they can be in Afib very short periods of time. So whenever they visit their doctor, everything's fine. Their doctor takes their pulse and they're regular. So in those patients, the symptoms can be mild, like they suddenly feel their heart taking off and going fast. They can feel an irregular heartbeat. They can just feel fatigue or tired and not know why. They can get short of breath or not be able to do as much activity as they could previously. Or they can have dizzy spells or fainting spells. Unfortunately, in a high percentage of these patients, the first presentation, the first symptom is a stroke. Those are exactly the kind of patients we want to capture before they come with a stroke. Like Dr. Ahmed said, you want to get to those stroke patients fast.
Dr. Ahmed, you have some articles that you have brought with you today that are very interesting, and I know you and Dr. A love to discuss things like this because it just continues to give you more information in your practice.
Well, I was just reviewing some articles, not necessarily for preparation, but I want to discuss with Mike. And this was a very catchy statement in a stroke journal. It said, atrial fibrillation and cryptogenic stroke. Look harder, look longer, but just keep looking. I mean, that was just a fascinating statement to make. And that's where I and Mike talk about how we can prevent strokes by looking harder, longer, and just keep looking. In fact, at the practice at Pikeville Medical Center, we have established rules that when we don't know what the cause of the strokes is, we get the cardiologist on board. Dr. Antomisaris and team get involved to make sure that it's not the occult or the Afib that we're not able to recognize. Keep them under telemetry, monitoring, and longer. In fact, we've got things that I'm sure Mike will tell us more, what we use at our hospital and anywhere else in the world and in the country to detect Afib that goes unrecognized in the hospital, during their stay, during their part-time when they're there in the hospital for a stroke. We take strokes very seriously and get Dr. Antomisaris and team involved to just detect the Afib that was not present during their stay.
For Naveed, he's always carrying a couple of articles in his pockets because whenever I see him in the hospital, he says, Mike, have you seen this article? So he puts it out. So he's very studious and he always gives us the new information. But this particular article is something that's been, these kind of studies have been ongoing for a long time. And we had, years ago, we do an EKG in the office and we considered that a good screening test. Patient's rhythm was normal. Then we had a 24-hour monitor and we considered that a better screening test. And then we had a 30-day monitor, so the patient would wear a monitor for 30 days, and we'd pick up more in patients with cryptogenic stroke. We'd pick up a higher percentage of patients, we'd make a diagnosis. Very important, because if you want to prevent a recurrence of the stroke, the patient has to be treated with very strong blood thinner medicines, which we don't take lightly. We don't take lightly because they have their own side effects. But if you're going to prevent a stroke, you're going to take some chance. You're not going to call it a chance because everybody would prefer a nosebleed to a stroke, let's put it that way, so you can get a blood thinner. So we have these new implantable monitors they're like half the thickness of my pinky. They get implanted as an outpatient. We probably could put them in the office with a local numbing medicine injection. It takes 2 minutes to put it in, and it's got a 3-year battery. It could stay there for 3 years, no complication or side effect, and it can monitor the patient 24 hours a day, 7 days a week, 365 days a year, for 3 years. And if there's any atrial fibrillation, we'll pick it up and we'll be able to get that patient on the proper medication.
So that would certainly help you detect and prevent the possibility of stroke.
Exactly. And so that would be something we're currently using in patients like Dr. Naveed, Naveed said, with cryptogenic stroke, where they've presented with a stroke. They could be young, they could be old, but we just can't pinpoint why this patient had a stroke. There's no atherosclerosis, there's no blockages in these arteries in the neck. And again, a lot of the patients don't have any symptoms of AFib, but the more we look, the more we find that those patients have AFib, and it's what caused their stroke, and it can be treated to prevent a recurrent stroke.
Certainly.
The other thing that Mike brought up, even if they've detected as AFib, only 16% of the people are taking oral anticoagulants. That's a sad story. Now, if you look at established patients with AFib, not taking oral anticoagulants is like, hey, inviting a stroke to happen at any time. The emphasis is on 1, early recognition of AFib, 2, treating it properly, and not worrying about the complications. Yeah, of course, there are complications. There are going to be side effects with the medications, but that's where we as doctors and the community work together to prevent those complications with better understanding how to monitor them and how to monitor the blood tests if they're on medications like warfarin or Coumadin to monitor their INR. But there are newer oral anticoagulants, and of course the emphasis is on A, recognition, early treatment, and being on those medications, even if they've had a stroke before, not worry about a hemorrhagic conversion, because a stroke, if it happens on oral anticoagulants, they're less severe than those people who are not on oral anticoagulants. Just before this talk today, I and Mike were talking about people are worried about having their next stroke, but they should worry about having a bad stroke, not being on oral anticoagulants, because those strokes are smaller and they're well sort of like organized in a way, the clot is well organized, than with those strokes not on oral anticoagulants. Right, Mike?
Right, absolutely, and we see that all the time. And the other thing is that even the patients that we put on the oral anticoagulant and they're taking it, it doesn't take much. So if they stop it for a few days, if they miss a couple of doses, if they're going to have another procedure and the doctor tells them stop it for a week, which is really unnecessary with the newer blood thinners. The newer blood thinners are in and out of the system within hours or a day. So their bleeding effect from surgeries after 2 days of being off these medicines is back to a baseline. So what Dr. Ahmed was alluding to is that at the time of presentation of the stroke, with patients even with AFib, only 16% were on the blood thinner at that point in time. So it could have been our good intention to have them on it, but they stopped it a few days earlier for something else, and then they had a stroke. And so they come in and, you know.
This was a recent study that was published and in the JAMA, and I was amazed to see that despite the emphasis has been there for past many years about prevention of strokes with atrial fibrillation, but under treatment and under recognition is still there. So we all are on the same page, I guess, that A, recognize early, treat them appropriately, and make sure that they don't go off of the oral anticoagulants for a longer time than they're needed, and God forbid have another stroke.
Right. Now that we have talked a lot about the diagnosis, let's talk about prevention. None of us want AFib, certainly none of us want stroke, but what can we do as far as lifestyle changes go to make sure that we don't have either of these two issues?
Well, to start off, we need to talk about the risk factors. One, age, of course, is a big risk factor. When we all get old, we have atherosclerotic changes in our large blood vessels, small blood vessels in the brain. That itself can cause a stroke. Hypertension. I mean, that's where the primary care physician and the cardiologist play a big role in trying to prevent the blood pressure from going very high. High cholesterol, again, that's a big risk factor. And lack of exercise, obesity, diabetes, and one big thing is smoking. Now, I don't know whether I've said this in the past programs, but we are in the stroke belt. The southeastern states, in fact, I'm one of the team members where we look at the stroke statistics happening in the southeast United States. It's a stroke belt, and Kentucky is very much part of the stroke belt. Any comments on that,
I
Mike?
agree with everything. So the risk factors to develop the AFib are really similar to the risk factors that if you do develop the AFib will increase your chances of a stroke. There's a scoring system. We call it CHADS or CHADS-VAST. All the factors that Dr. Ahmed alluded to or stated are all included in that scoring system. Hypertension, diabetes, and even factors that aren't directly included are contributories, like smoking, like you mentioned, bad diet, obesity, and sedentary lifestyle is very bad. So all those things increase your chance of getting AFib and increase your chances of getting a stroke if you have atrial fibrillation.
Even TIAs, what we call as mini strokes, are a big risk factor for a stroke to happen. So we need to take our TIAs or mini strokes also very seriously because you don't want to have a full-blown stroke.
Talk a little, you mentioned mini strokes. Talk a little bit about that. That's something we hear a lot discussed with people who maybe have had a major stroke. The mini strokes that come in, what exactly is that?
By definition, it lasts for a shorter period of time and the symptoms resolve without any residual symptoms, be it blurred vision, be it facial asymmetry, be it speech disturbance or weakness in the arm or numbness in the arm. But again, the emphasis is to come to the ER. Don't make that diagnosis by yourself or your neighbor telling you it's a mini stroke, stay at home. You're better off coming to the ER, being evaluated. Of course, we do the workup, and if there's no damage done, then it's called a TIA. What I mean by that is if you do an MRI and you don't find a lesion there, by definition, it's a TIA.
Let me just take advantage of this, and I need Naveed to teach me things. So I'm going to take advantage of us being here, let him teach me something. So typically in the past, we'd call it TIA. The typical TIA when I was in medical school was a patient who came in and lost vision because he had a plaque in his carotid and he threw something. And then you said something before that I think my mind's working slowly, but you're going to help me out here. So patients on a blood thinner, the kind of stroke they get isn't as bad. In fact, can it be converting some patients that would have been having a big embolic stroke to a TIA-like presentation.
That's very much true. I mean, in the past when we had this coumadin as an oral anticoagulant, if their INR, if the blood was not adequately thin, the very fact that Mike was telling the blood doesn't get pumped, forms a clot, you could just flip an emboli. The anticoagulation is not working in perspective of atrial fibrillation, or there could be a clot because of the atherosclerosis in the carotid artery, could be a small plaque that goes up to the blood vessel that supplies the eye and the vision. So these are transient events that get better. Now, by definition, in the past, it used to be so many hours, 12 hours, 24 hours, there was different diagnosis, but now it's a resolution of symptoms to normalcy within a few minutes. And two, if you do an MRI, there's no lesion. It's a tissue diagnosis. So yes, you're absolutely right, Mike, and not recognizing that oral anticoagulants like coumadin, if the INR is not monitored closely, they can flip a clot. They can form a clot and flip an emboli.
Yeah.
Fascinating to hear the two of you discuss your specialties, and like you said, you learn from one another as you continue your treatment, and that's where I want to go to next. Treatment of stroke. After it has happened and we have everything under control, what does the treatment look like while they are in the hospital?
Well, the immediate treatment, if they meet the criteria, is TPA. It's like a big clot buster that we call. If they come to the hospital within certain period of time, 3 hours, and in certain conditions within 4.5 hours, if they meet the criteria, there are no contraindications, then they are eligible for TPA, and that's given at our primary stroke center at Pikeville Medical Center ER. And with the teamwork that we have, a code 100 is initiated, and if they meet the criteria, TPA is given, and then they are admitted to the intensive care unit. If for some reason they don't meet the criteria, even those strokes are taken seriously, and we look for a clot in the blood vessels in the brain, and there's intervention that we can be used, and we hopefully get them there where it's done and get the clot out of the brain system. So there are many ways we approach it on an acute basis, and subsequently when they are treated on an emergent basis in the ER, they are admitted to the stroke unit or the ICU, and then of course we get Mike and the team, the whole team is involved. We do ultrasounds, echocardiograms, find out the cause of the stroke, and then treat it appropriately.
Let me just say one other thing. So 8 years ago when we first moved to Pikeville, so often we'd hear over the speakers, code 100, code 100. Didn't know what a code 100 was, so I kept asking, what is this code 100? I hear about 5 to 10 times every day. It's a lot. And then finally it was the code for a stroke. The neurologist has to get on the phone or get there to evaluate the patient for this clot busting medication. Well, I was in a big hospital in Lexington at St. Joe's for a long time. They never gave those things back then. So this is a huge, and it's a lot of work. I mean, 5 or 10 times a day, Dr. Ahmed and Dr. Goudian, they get called in to evaluate patients all the time to establish this. And it's a huge advantage, because if you see a patient come in with a really bad stroke and like an hour later be back to normal after they get the clot busting, there's nothing like it.
Very true. In fact, I had one patient not too long ago. He received the TPA, was in the ICU. He said he wants to go home. There's nothing wrong with him. Of course, that's a group of patients that do very well. And of course, there are complications with TPA as well. 6% to 7% of the people appropriately treated with the TPA can have hemorrhagic conversion. They can have an anaphylactic reaction to the TPA like any other medication. But of course, we deal with it on a case-to-case basis. But TPA is an approved medication for using in ischemic strokes if they meet the criteria.
What about the recovery time from stroke? You and I have talked about this in previous programs, but the recovery from a stroke can be simple to pretty extensive.
Well, it depends on the severity of the stroke. I mean, we talked about how this patient in the ICU was totally normal after TPA and he wanted to go home. But there can be deficits depending upon, despite the adequate appropriate treatment, people do have damage, what we call as ischemia, lack of oxygen, and if you're not able to treat it, then that reflects by weakness, paralysis on one side, speech disturbance, swallowing problems. And we are very happy and honored that with the support of the administration, we have a rehab hospital at Pikeville Medical Center. People don't have to go far off to get better, be able to walk, talk, eat and drink after they've had a stroke. and we have good support service. We have a stroke awareness, and we've got all things that are, God forbid, if they have a stroke, to meet at Pikeville Medical Center. You know, from acute care to rehabilitation and post-care as an outpatient rehab. I think we are blessed to have Pikeville Medical Center with all facets at every stage.
My last question to you is going to be, how well prepared is PMC to treat patients with AFib, stroke, and rehab? And certainly you just alluded to each and every one of those. But I know the one thing that we do want to stress to our audience today is, if you start to have symptoms of stroke, if you start to have symptoms of what you may not know as AFib at the time, but you feel the fatigue, certainly get to your physician, get to the ER if you think it's serious enough, because time is so of the essence when we talk about each of these symptoms.
Absolutely. In terms of the AFib and the blood thinners, there are a group of patients that blood thinners are very problematic and we really can't use them, but they still have a high risk of stroke. And there's some new procedures that we're going to start doing in that respect for devices that actually mechanically occlude the area in the heart that forms stroke, that forms the blood clot, and that causes the stroke. And those are going to be available here very shortly too.
Certainly Pikeville Medical Center always does a wonderful job of bringing the latest and greatest treatments to the people of our region, and providing each of you with the tools that you need to make sure that quality care is of utmost importance. Dr. Ahmed, as we come to a close today, you and I have talked a lot about FAST, but we want to just reiterate again how important it is if you start to have these symptoms of stroke, because time is really what we need to focus on.
Well, again, I think that acronym is very meaningful by itself. FACE stands for F for face, it is facial asymmetry. Any weakness, asymmetry. S for speech, time is brain. Just to reconfirm what we all said, please take your TIAs, strokes, and AFib seriously. And do not say, hey, I'm going to get better. You will get better if you're appropriately treated, recognized, and make sure that your doctor, the family, understands that stroke risk is huge in this country, especially in Kentucky, because we're in the stroke belt.
It has been fascinating to sit and listen to the two of you talk back and forth with one another and discuss how we treat our patients from Pikeville Medical Center and how you all work together as a team. So thank you so much for your time.
We are blessed to have a great cardiology team from Dr. Bill Harris, Dr. Ahmad, Mike, and everybody else to help us with the stroke group and stroke team. We're honored to have you, Mike.
And we're blessed to have a great stroke service. We really are. I mean, if you compare it to the way I remember from Lexington to what I found here, and that's a while ago, so it's come a long way since then. So.
True, very true.
Love to see how you all work together to make sure the people of our region stay as healthy as possible. And certainly if you think that if you have any of these symptoms that we've talked about today, get to the hospital immediately. Do not put it off, and certainly do not sit at home and think you can diagnose yourself. And that happens a lot, I know, with some of our patients. Certainly if you have any questions about AFib or stroke, we invite you to call Pikeville Medical Center at 218-3000. Let them know what is going on, and certainly we want to do our very best to take care of you. Dr. Ahmed, Dr. Antamasiaris, thank you all so much for your time today. It has been a delight and certainly fascinating.
Pleasure.
It's an honor to be with Mike here and you. Thank you.
This has been Health Talk, a service of Pikeville Medical Center, proud member of the Mayo Clinic Care Network.
Thank you.